All right. Well, hello, everyone, and thank you so much for joining us. The Southeast Mental Health Technology Transfer Center would like to welcome everyone to today's event, Inpatient Care and the Road to Recovery. My name is Emily Moore, and I will be moderating today's event. Quick disclaimer, please note that the work of our center is supported by a grant from the Substance Abuse and Mental Health Services Administration, or SAMHSA. And also, please note that the work of our center and that of the larger MHTTC network all use affirming, respectful, and recovery-oriented language in all of our activities. Quick word about our center and our work before we get started. The Southeast Mental Health Technology Transfer Center is proud to serve the 8 states in HHS Region 4. Our expertise in public health programs, systems, research, and evaluation provides a unique lens through which we can address mental health priorities. We encourage you to visit our website at mhttc.org/southeast to learn more about our center and our upcoming events. A few important notes before today's event. This webinar is being recorded and will be made available on our website for on-demand viewing soon. We encourage you to share your comments throughout the presentation using the chat feature, but please remember to select chat with all attendees if you would like to share your thoughts with everyone. We've also allotted time at the end of our presentation for questions and answers. Please submit your question using the Q&A feature at the bottom of your screen. And finally, for any participants who are interested, we do have a certificate of attendance available for download upon completion of our evaluation surveys. I'm going to go ahead and introduce one of today's speakers. Michelle Sawyers, PhD, is a professor of psychology at Indiana University, Purdue University, Indianapolis. She directs the ACT Center of Indiana, a collaboration of academic and community partners, including researchers, administrators, clinicians, consumers, and family members who share an interest in recovery-oriented, evidence-based practices. The overarching goal of her work is to help adults with severe mental illness lead meaningful lives in the community. Her research addresses both consumers of mental health services and the providers of those services. She is increasingly targeting the interaction of consumers and providers, looking for the best ways to support relationships that promote recovery and well-being. Her current work involves developing effective ways to reduce staff burnout and to increase shared decision-making in mental health care. And later on in today's presentation, Dr. Salyers will be introducing her co-presenter, Emily Bass. But I'm going to go ahead and turn it over to Dr. Salyers so that she can start today's presentation.
Great. Thank you. Can everybody see the slides? Great. So I'm delighted to be here and to be back. So some of you may have seen me in the past presentations with palm trees, and I am now back in Indiana again. So happy to be home and presenting on this topic about inpatient care and what is the role of inpatient care for recovery. So our time together, we'll start with a little bit of background and the history of the role of the hospital. I'll share some of my own personal views and talk about hospital care and recovery-oriented care and how those things have sort of evolved. And then we'll get into a particular study or series of studies that we've been involved with in looking at how is recovery translated to hospitals in one really large system. So looking at the VA hospitals across the US and really kind of looking more detail about what does it mean to be recovery oriented when you're working in a hospital, or I know many of you who signed up are working in outpatient kind of settings, but you might have people who you're working with in the hospital as well, and so how to coordinate with them. And then the last part will be more about what it's like to try to do recovery-oriented care in practice. in hospitals. So first, before we go into all of that, I wanted to see what you guys think. And so this is for our little poll. What do you think the role of the hospital is? Is it a retooling station where people can come and get new tools, learn things about recovery, and or is it more like a pit stop where you're in and out, just getting the bare minimum to get you back on the road fast? Or is it a total wrong turn for recovery? So take a minute and just let us know, if you had to pick one, what's your view of hospital care? We give that a few seconds for Stephanie to get all the answers together. Retooling station is the biggest one. Great. Pit stop. And then a few people, maybe the wrong turn. Thanks for sharing that. So my personal disclosures on the role of hospitals, and my view has changed over time in different ways. So first, I was trained as a clinical psychologist and really focused on psychiatric rehabilitation. So my program, that was the main focus, the psychiatric rehabilitation. And when I was in grad school in the early 90s, that's when the word recovery started being used instead of psychiatric rehabilitation, really. That I actually remember the day my advisor came in and said, Bill Anthony wrote this paper, and now we're all focused on recovery, not rehabilitation anymore. But back then, my work was really centered around assertive community treatment and doing several studies on how to implement that in the community. And the focus there was to build this hospital without walls, where people could get the same intensive services but be in the community. So with ACT, or assertive community treatment, the idea was you wanted to try to avoid hospitalization, and that you could really treat people even with the most severe disorders in the community. And so we were sort of thinking of it as a wrong turn, maybe, or at least a short kind of stay. Then when I was in grad school, my brother actually was diagnosed with a severe mental illness and had a lot of substance abuse issues. And for him, he would often disappear for months at a time. And I remember when he came back and got into treatment, he was in a state hospital. So he was there for several weeks. And I saw the hospital at that time as the safe haven. And it really was a little different from my view of everything should be done in the community. When I saw my brother in a place where he was safe, he had 3 meals a day. He was able to work at the fire station and had a meaningful role in helping keep things clean, and he was happy there. And I saw my mom feeling happy that he was there. And I thought of the hospital as it is a retooling station. He was learning new skills, but part of me even wanted him to stay because he was doing so well there. So that was kind of a shift for me in thinking about hospitals. And then most recently, my husband has had some cardiac problems. And so we have been in the hospital for medical reasons quite a bit over this past year. And the medical view of the hospital, it really is a pit stop. They don't talk about your long-term prognosis. They don't talk about what's going to happen much after the hospital. We were there to get him fixed as much as they could, and then the rehabilitation or that recovery stuff happens later. So that's another view of kind of hospitals and what their role might be. I thought it would be interesting and helpful to give a little bit of a historical view as well. So hospitals really started as asylums. Back in the 1700s, they really started expanding in England and France, and then in the US. And the idea of an asylum originally was the sanctuary or retreat. So putting people in a nice place kind of away. And around that same time, well, a little bit later in the 1800s, we started seeing more of an emphasis on treating people. So not just putting them away somewhere, but that we needed to treat people with kindness and to help them and give them companionship and shelter. And some of the leaders in that area were Benjamin Rush and Dorothea Dix as early US leaders. So you've probably heard their names. And around that time, in the mid 1800s, medicine became more formalized as well. And so they changed the name from asylum to a hospital or a clinic, and inmates became patients. And here is a picture of our state hospital when I was in graduate school. This was about to close, and it was a huge deal in the early 1990s that people were really worried about what was going to happen when we closed the hospital. And I need to give a caveat here. I'm going to show this report from when the hospital was being planned, and it does not use recovery-focused language. So a friend of mine who worked at the State Division of Mental Health found this old report back when the hospital was being planned in 1845. And so the report title, the subject of Hospitals for the Insane, and the commissioner of the Lunatic Asylum of Indiana, which is terrible now when we think of those words, but back in the 1800s, that's what they were calling it. So if you have your chat and can put into chat, when you think of a hospital for the insane or a lunatic asylum, what would be an adjective that you might use to describe that? And I'm trying to find chat on my screen. There we go. So just type in maybe a word or two that comes to mind when you think of a hospital in that context. Okay. Well, I am not seeing anything. I don't know if it's my chat isn't showing anything. So I'll just move on. But this is actually a paragraph from the report, which I found fascinating. So the person who was telling them how they should build the hospital in the plan said it should be a delightful retreat from the turmoils and perplexities, where people can enjoy the comforts of life, the kindness of friends, at a home of contentment. And that just seems so different from how we might be thinking about hospitals with those. Oh, chat is disabled. I see that. Okay. Yeah. Thank you for letting us know in the Q&A. So with the historical view, at the same time that asylums were shifting to hospitals, we started seeing the development of new treatments, and a lot of them were trial and error kind of treatments just to see what would happen, unfortunately. But they were also starting to develop different medications and things that were effective and became more medicalized. But the larger kind of asylum type hospitals became really kind of dumping grounds, and people became segregated from society and included anyone who was considered undesirable. And so there were a lot of abuses and bad living conditions that came about in those settings. And so for people who are interested in kind of the old way of hospitals and kind of how they came about, this was a really interesting read that was several years ago now, a book about in finding actual suitcases and things that were in an old state hospital system. So that was fascinating. But sadly, for Central State and many of these hospitals, that vision for this delightful retreat was never realized. And in 1870, there was actually a report to the governor by the superintendent at that time describing what he was seeing, where people were kept in the basement, and just this terrible scene about people who were raving and howled like they're being tortured, not having air and food and light. And so there were a lot of abuses in the system, and eventually Central State actually closed in a large part because abuses continued as well. But it also closed because in the late 50s, early 60s, we started seeing the community health movement, where we were trying to get away from hospitals and really care for people with severe mental health concerns out in the community. And that came from several different factors that kind of led to that. So there were lawsuits around some of the abuses. Of course, politicians are interested in the economic benefits as well. And so it was maybe cheaper to serve people in the community. And the Kennedys had a sister who had been institutionalized. And we were also starting to see more effective treatments where people could be treated more easily and could live in the community. And there was also a lot of civil rights activism at the time. And so the idea was that we would develop these community mental health centers, and they would coordinate with the medical centers for care. And Dr. Druss, as part of this seminar, he wrote a paper back a while ago now, but about the history of integrating that physical and mental health care. So if you're interested in that. And then the community mental health movement started moving more towards managed care, reducing costs, and it came back to the idea of wanting to get people out fast from the hospital. And then that brings us to the recovery movement that really a lot of people have been pushing for recovery ideas for a long time. But it was really in the 1990s when Bill Anthony came out with his seminal paper about this guiding vision for the mental health system. And because things moved slowly, it took a while before we started seeing national policy documents that were really pushing this idea of recovery-oriented care. And since that time, we've had more than 20 years of measuring recovery and implementing recovery-based care. And most of that has been in community or outpatient settings. And that's been a big focus of my work and my interest is how do you do services in a way that supports people to pursue their dreams, their interests, and manage their illnesses more independently. And so that's been a big part of what I've been interested in. And the VA hospital system came out with their own policy statements. And in 2013, they released a mandate for inpatients to start doing recovery-focused care. And so they came out with a handbook and a checklist. These are all the things you should have to seek this vision of a clinical care that encompasses not only patients, but staff engagement, and that we should empower patients that we work with and help them have a sense of hope. And that we should provide an environment that is by design, healing and therapeutic. And I think it's interesting the parallels from the ideal vision of hospitals. Our own hospital in Indiana was supposed to be this sanctuary and retreat. So we're coming back to the sense of a warm, welcoming kind of place that would be home-like for people to recover. So from that mandate back in 2013, we were really interested in seeing, well, what does recovery-oriented care look like on inpatient units within the VA system? Now that we have this guide out there, what are people actually doing and what does it look like? And so Emily and I worked with Alan McGuire. He led this application to evaluate recovery orientation in inpatient settings. And it's kind of interesting to think about this, that an idea that we might have had in 2013, by the time you write the grants and submit the research study and do the research, it's now 9 years later. And so it does take a while to go from idea to actual getting studies out there. So still a slow process. But the background for this study, the VA did create this system-wide mandate. They had a handbook for care. And so we had two main aims. One, how is it being implemented? And we were also interested in some of the barriers and strategies that people were using to overcome the barriers to do recovery-oriented care in an inpatient setting. And we were also interested in seeing, is recovery-oriented care related to better veteran outcomes? And so that was our second aim. And we partnered with the National Office for Mental Health Services in the VA. And we recruited 34 different inpatient settings across the entire US. And we did site visits for all of them. So we had 34 sites. We did site visits that would be about 2 days at each hospital. And there were 1 or 2 people who would go and visit, and we would interview key informants. And so we talked to staff and the inpatients who were on the unit. We did observations. So we went to treatment meetings, and with permission, we went to intake and discharge planning meetings and things like that. And we also looked at administrative data. And sometimes we just kind of sat around and watched what was happening. And so it was like a brief ethnography, mini ethnographies at all of these different sites. And that was a really interesting study to me. I was excited to be one of the reviewers, site reviewers. We would go and visit the sites. And that resulted in our first aim, came out last year, and looking at recovery-oriented acute inpatient mental health care, operationalization and measurement. So what does it really look like? So for this aim, we started with that checklist that the VA prescribed, and then we made items with behavioral indicators, like how would we know it if we saw it? And so we started with 33 items, and some of them were easier than others. So for example, the VA said veterans should be encouraged to wear street clothes. That was one of their items. And so that's pretty easy. you can see people wearing street clothes or not. If they're in their pajamas, you can ask them if they are wearing pajamas. Maybe they've chosen that. So that's pretty easy to measure. But some of them, like shared decision making for medication, in the VA, they had treatment plans should indicate shared decision making. Well, if you look at treatment plans, it's really hard to know how those decisions came about. Often it's difficult to tell from the treatment plan itself. And you really need to see and hear, how are people talking about medications or decisions about treatment? What does that really look like? And so some of these are easier to measure than others. And so part of our process was that we would do our site visit. We would start with those ratings. We would make observations about what we saw, either supporting or not supporting each element. And then a group of us, there were probably 7 or 8 of us at most of those meetings, sitting around the table talking about the visit and how well the items were working. And then we went back and kind of revised the items over and over again. And it was a really interesting process to be able to be invited into these different sites and work with them and see what they were doing. And at the end of the site visit, we also would give them feedback, have kind of a wrap-up meeting as well. And then we have some kind of a shared listserv where they can get information back after the study as well. So through this process, we identified 4 main domains for recovery-oriented care in an inpatient setting. And I'll go through some of the items for each of these domains just briefly, so you kind of get a sense of them. But really focused on how are you planning and doing treatment in the setting, and then for outpatient care. So often we would hear, as soon as the person comes in, we're immediately planning for outpatient discharge. So those are the 2 main planning areas. And then often on inpatient units, it's mostly group programming. There are some places that have individualized psychotherapy as well, but around a lot of it's around group programming. And then the milieu, or the environment, what is it really like there? So inpatient treatment planning should be a collaboration between the patient or veteran or client, consumer, and the staff, and also family members or significant others. And so there are several things that we were rating sites on. So our goals really focused around the person's own recovery goals. Are those goals written in a comprehensive treatment plan that all of the staff have access to? Not only is there shared decision making for medications, but we also expanded that for other treatments, like which groups you're going to go to, or whether or not you're going to seek individual therapy. And of course, inpatient units usually have interdisciplinary treatment teams, but we were looking for a breadth of them, not just nurses and doctors, but social workers, psychologists, the chaplain, peer providers, occupational therapists. So having a range of people. And then we were interested on what happens after the stay. And recovery-oriented care should still be patient-focused, and really, how are they making decisions about where they're going to go after inpatient treatment, and what are they going to do? And so looking for the least restrictive setting when they're discharged. How are they going to coordinate care with outpatient? So often, especially with long-term hospitalization in the past, people would be discharged and then kind of disappear in the community. And we don't want that to happen. So how are you going to coordinate care? And one of the good ways about doing that is doing in-reach, where outpatient providers are making connections while people are still in the hospital. Maybe they're providing groups, maybe they're coming and visiting people who are about to be discharged to them. And so that's one strong way to do that recovery-oriented in-reach. Group programming. So within the VA, they were very specific in saying you should have at least 4 hours a day or more of therapeutic options for people to go to. They should be evidence-based and diverse in their topics. And so we would expect everyone to have groups related to mental health management, substance use, trauma-related groups. Often we would see self-care groups, but also some of the lifestyle kind of groups, physical health, relaxation. Some places we went to, they had Tai Chi, where they would bring in pet therapy. They did different things like that. And then last, the milieu. Is it a warm, inviting place to be? And this is kind of hard to measure. So you're in an inpatient setting where people are there because they were in a crisis. And there might be a lot of safety issues, and there are regulations around safety. And so we kind of talked about having, like, you would see Flintstone chairs that are too heavy to pick up and throw, but they should still be comfortable to sit in. So looking at things like that, and also, are they able to wear their own clothes? Can they stay up? Or do they have a set bedtime, those kind of things? And how are they interacting? And so these are the 4 areas that we really looked at for that. And if you're interested in the actual paper too, you can contact me because it just came out and I can send you copies too. Our second aim was to say, okay, now we know what recovery-oriented care is supposed to look like. Is it related to veteran outcomes? And so we looked at those same 34 sites. We looked at those domains, and then we pulled administrative data from the VA system and looked to see, do those predict who is readmitted within 30 days? And so that's a pretty extreme example of someone not doing well, is when you come back to the hospital so soon. And so we looked at whether they were readmitted or went to the emergency department with a mental health diagnosis within the 30 days. And so, drum roll, overall, the overall scale score was not related to veteran outcomes, but a few of the items were, and those were the therapeutic items. And so the settings who provided individual evidence-based care, they were doing a lot of group programming with high quality groups and had the multiple disciplines. Their veterans were less likely to come back to the hospital. And so those were the items that were the key things, at least related to readmission for that. So this is where I'm going to turn things over to Emily Bass. And Emily is a 4th-year graduate student who works with me, and she does psychiatric rehabilitation and recovery. She's very interested in quality of care for people, and especially in inpatient settings. She's been involved in several of these studies and has also done clinical work. So I thought it would be fun to co-present, and I will turn it over to her now.
Thanks, Michelle. So now that we've learned a little bit about what recovery-oriented care looks like on inpatient units, I wanted to share a little bit more about a couple projects that I've worked on related to different elements of recovery-oriented care and what those might look like in practice, and also sort of my experience working as a clinician on an acute mental health inpatient unit. So this first study I wanted to talk about used data collected from that original RAIN study that Michelle just spoke about. And we analyzed qualitative interviews across staff and across those 34 sites. And we also looked at the observational notes from those sites. And our main goal was to better understand implementation and understanding of shared decision-making for medication management on inpatient units across the VA. And we also compared sites high in shared decision-making with sites lower in shared decision-making that had been rated previously, using those elements from the items developed in the original RAIN study. And so I have those listed here, but basically they are discussion of veterans' needs and preferences, risks and benefits of medication and alternative treatment options. Conversation begins and ends with veterans' interests, preferences, and involves their input in their overall decision-making process. Active use of decision aids to facilitate veterans' understanding. Use of teach-back technique to evaluate veterans' understanding of the information. And veterans have the option to decline medication treatment. So we also looked at sites and sort of compared them on how they ranked on those elements as well. So let's see, what we found was that shared decision-making was often described along what we classified as this power sharing continuum. And so for no power sharing, the patients really were excluded from the medication treatment decisions. All decisions were kind of going through the providers. With limited power sharing, patients were informed of treatment decisions, but had limited influence on those decisions. So providers thought or viewed their role as more to convince the patients to take the medications or to gather veterans' opinions and preferences, but the doctors ultimately made the final decision. And then shared power was patients, providers worked collaboratively, and patients were allowed to contribute to medication decisions. And this included things like relationship building between the psychiatrist and patient, eliciting goals and preferences from the patient, patient education, and then multiple treatment options being provided to the patient, including the option to not take medications. And we also found that only the observational data from site visits differentiated top sites from bottom scoring sites on those that RAIN shared decision-making scale that I talked to earlier. So specifically, all but one top scoring site indicated shared power medication decision processes, whereas the bottom sites reflected mostly no power sharing. And this really tells us that the staff we interviewed may have a conceptual understanding of shared decision-making, but ultimately may have some difficulty implementing this on a regular basis. Additionally, things that were sort of helpful to facilitate shared decision-making implementation, some themes that we found were inclusion of the veteran in treatment teams. So successful sites often describe that the patient as a valued member of the treatment team and involve them in discussions about medications and treatment. However, this was often not the majority of the units. Less than half actually did this. So it's also important that the veterans understand their role in the meeting. So oftentimes if veterans were included, they may not speak up much because they're in a room full of doctors, medical students, residents. It might be quite intimidating to speak up. So clarifying the role for the patients and that they do want the veterans to speak up if they have preferences and needs that aren't being communicated well is important. And then patient education. So pharmacists and peer support specialists were helpful in sort of providing groups on information about different medications and treatment options based on different symptoms. And this sort of better equipped patients to engage in informed decision-making with their doctors. It also helped empower patients to sort of lead a more active role in their treatment. And then the last one is respect for patients' autonomy. So in the high power sharing sites, patients' autonomy was often patients were often described as having autonomy, as individuals with capabilities and basic rights to be involved in their care. In contrast, in the observational notes for low power sharing sites, they were often described as veterans who are new to the patient or new to the inpatient unit, unfamiliar with shared decision-making processes, or those with certain diagnoses like psychosis, were not as supported in participating in shared decision-making processes. So another study we conducted looked at the use of veteran-facing e-health on inpatient units. And e-health really has the potential to support recovery-oriented efforts. So thinking about things like video chat from the unit, it can help with inpatient, outpatient coordination. If you can't, be an actual visitor to the unit, you could potentially set up a video encounter with the person. It also helps with discharge planning. I've seen some patients be able to sort of tour facilities and things virtually through using e-health. It also helps to maintain connection with family. So not all inpatient units are accepting visitors due to restrictions still standing from the pandemic. And also, veterans that may live in more rural areas that come into cities to receive care their families may not be able to travel long distances to get to visit the patient. So it is important to still maintain that connection, and that can be done through things like video chat. It also helps to support a home-like environment. So, veterans have access to these things at home, patients have access to these things at home. And so limiting their access in the inpatient unit may not necessarily serve their needs if they need to sort of learn better ways of using these e-health technologies. So we basically surveyed 49 providers across 37 acute mental health inpatient sites. This was across the VA to gather data on the use of veteran-facing e-health technology and also on implementation efforts. So we found that less than 20% of inpatient veterans were using most types of e-health on the unit. We also found that video chat and tablet use seemed to be the e-health technologies that many sites have tried to implement to varying degrees of success. And they're also the ones that sites would really want to try and implement in the future. And so due to this, we also interviewed a select number of sites who are successful in tablet and video chat use, and those who are not successful but desired more use. And so from the surveys and interviews, we found multiple barriers to e-health use, such as staff shortages to supervise patients with the technology, or lack of proper equipment to support e-health in a safe manner on the inpatient unit. But I wanted to highlight one major barrier that came up that I think many of the other barriers sort of boil down to, and this is are connected to, and this is safety and privacy. So some sites specifically mentioned recovery orientation and viewing patients as adults with autonomy, using technology as part of the therapeutic process. And so successful sites tended to view safety or privacy breaches caused by e-health use as exceptions rather than inevitable outcomes. And because of this, these sites tended to handle safety and privacy concerns more on a case-by-case basis. And this quote here at the first quote on this page kind of highlights an example of that. And then less successful sites were quick to put in limits, viewing the acuity of patients or the mission of inpatient care as necessitating restriction, which is highlighted in the second quote, where someone had an incident using e-health technology, and then the unit banned the use of it for everyone. And I think this sort of speaks to implementation of recovery-oriented care in general on inpatient units. So there's very real challenges that are unique to inpatient, and safety and stabilization are very important parts of the equation and definitely should not be overlooked. However, these things aren't inherently incompatible with the idea that each patient has the right to some degree of autonomy on the unit. And every single part of recovery-oriented care may not be implemented perfectly with every patient across every inpatient unit, but I think it's important to also not completely rule elements of recovery-oriented care out for the sake of safety. So I also wanted to share just sort of examples from my experience working on an inpatient unit. I worked as a psychologist in training over the past year on an acute mental health inpatient unit in the VA. And so some of the challenges that I saw were really the balancing of safety and patient autonomy. These things can often conflict. And I'm using examples from the unit I worked on, and some things I think they did well, some things they could improve on, but ultimately they're not ruling out recovery-oriented care altogether. So patients could wear their own clothes if they'd like to. They weren't allowed to wear like shoes with shoelaces or belts for safety reasons. Patients did not have access to their cell phones on a regular basis. However, they were allowed to use their cell phone or get numbers off of it with supervision from a social worker or nursing. Patients were allowed to go in and out of room during the day, but they were encouraged but not forced to attend groups. So they really were encouraged to go to groups. We would invite them to groups, but ultimately it was their decision. Another thing that people don't often think about is sort of what is the readily available to patients on the unit. So patients on the unit had to ask for water at the nursing station anytime they wanted water. They did have sinks in their rooms, so they could potentially get water from there, but that's just like one thing that highlights patient autonomy and things that we don't often think about on the unit. And there were challenges with that because, some patients for medical reasons had could have limited like liquid intake that they had to monitor. So ultimately they decided just to make the water available at the nursing station and they could get it whenever they wanted. So the next major theme, so I sort of noticed when working on inpatient, was balancing shared decision-making with things like mandated treatment or legal guardianship. And so, patients often refuse medications for various reasons, and staff really try to inform them of the benefits of the medication. They often gave them choices in the types of medications based on various side effects or things that they've tried in the past. And staff also really try to take it day by day. So if a patient was not feeling medications that day, refusing them, they would, be like, okay, well, let's try a different time or let's try a different day and see how they feel. They also were allowed a little bit of autonomy in the time of day medications were taken. So if veterans were having side effects like drowsiness and they preferred to take their medications at night rather than the morning, that could be accommodated. Social work and patients worked very closely together for discharge planning. So this could look, they would work to understand where the patient would like to go and what their ultimate goals for their recovery were, and then work to try and place them in, as feasible as possible, a place that sort of adheres to those goals. This could be difficult sometimes because sometimes the patients wanted to be discharged back into an environment that maybe would not serve them well to their recovery. But ultimately, sometimes, we had to go with what the patient, their preferences were. And because ultimately, if you try to force someone to go somewhere that they don't want to go, it's probably not going to go well. And then there were often challenges related to acuity of symptoms and medication management. So, sometimes individuals would come in acute crisis and they may be unable to make these types of decisions immediately. However, I did see times when after the patient had improved over a few days, they were more involved in their care. And it's important, I think the lesson in that is that it's important not to rule out shared decision-making altogether just because of their presenting acuity in one moment, because things change rapidly on inpatient units. And then lastly, patients were not present during the treatment team meetings on the unit that I worked in, and psychiatrists met with them individually before meeting, and then every day we talked about each patient in the treatment team meeting. And I talk a little bit more about this later on, but I think it's important that there is a degree of patient advocacy during those meetings if the patient isn't present in the treatment team meeting. So lastly, I just wanted to share a few lessons I learned working on inpatient as they relate to recovery-oriented care, and then things that I observed that were helpful for outpatient providers to do. So it's really important to meet patients where they are in their recovery. So this could mean simply listening to their story and providing emotional support. My supervisor used to say that we're often meeting individuals during one of the worst days of their lives. So giving them time to process this with you before jumping into skills is really important. And really understanding the patient's goals for recovery while in the unit, and then also beyond that, and tailoring your treatment accordingly to those goals. The next thing I noticed was that I found helpful was patient advocacy during those treatment team meetings. Like I mentioned before, the patient isn't always involved in those. And so really having a willingness to make sure that the treatment team understands the goals of the patient is important. And then lastly, individual invitations to groups is really important. I think the highest group attendance that we had was when veterans had relationships with the group leader. And so going around and inviting each patient on the unit to group individually and kind of telling them what the group's about and what you'd be doing that day often really helped improve group programming attendance. So from an outpatient perspective, I think it's really important if you're working with a patient who goes on inpatient to stay in contact with that patient. And this is another benefit of eHealth. If you can't go visit the patient, you can call the unit, or you can video chat if that's available on the unit. And this, I often saw, so we actually had one fellow who really did not want to be on the inpatient unit and was quite angry about it. But he had a caseworker from outpatient that came in, worked with him a lot, almost every day. And when the caseworker came, his total demeanor changed. He was very happy to see him. He gave him a hug. And so it's just nice to have, for the patients to see those providers that they've developed a sense of trust with on inpatient. If possible, it's really helpful to help coordinate outpatient care with inpatient social work if your patient is on the inpatient unit. Michelle did mention that a little bit. And we did have a question in some of the questions you guys submitted about peer support helping in this process. And I think that's a really good point. And there is research to suggest that it is helpful for peer support specialists to sort of help the patient post-discharge, navigate outpatient services to help them. It also increases empowerment and engagement in those services. So I think that's a really strength to peer support specialists. And then lastly, I think it's important to spend time processing the patient's experience of inpatient with them post-discharge. This can often be really traumatic for patients, whether it be the event prior to inpatient being traumatic or the inpatient experience itself. And so spending time to process this is important. We often make safety plans while on inpatient, and those get lost as soon as they leave. So it's important to maybe review safety plans with them post-discharge, and then think about what their goals are for recovery moving forward. Oftentimes, maybe people think that it is, a wrong turn in their recovery. They might feel disheartened that they ended up on inpatient, but really thinking about hope for the future and goals in their recovery moving forward, I think is important. So yeah, that is all I have.
Great. Thank you, Emily. So we're at the place where we can take questions. So I think our other Emily will let us know what questions we should be answering.
Yes, thank you so much, Michelle and Emily, both of you, for this amazing presentation. We do have one question in the Q&A, the Florida Department of Children and Families did say, you may get to this in future slides, but wondering what the scale up was for this effort among the various domains, training, TA, implementation, guidances, ongoing monitoring, etc. And then, yeah, just repeating that same question, what the scale up would look like for this effort.
Yeah. So within the VA, there's often the policy starts first and sort of this top-down kind of mandate of here's what you should all be doing. I think they have monthly calls with inpatient coordinators who can talk to each other, but there wasn't a big implementation effort in terms of like training and those kinds of things for this particular mandate of care. And that's in part why we really wanted to do that study, was to see, well, what are people doing? We didn't really know. One thing that the VA has done really well with recovery-oriented care is having local recovery coordinators. And so those are people who are designated to keep the idea of recovery alive and to work with other providers to do that well. And so local recovery coordinators can work with inpatient sites to kind of help them think about recovery. So that was happening in some of the places, but there wasn't a systemic kind of effort. I will say, as we used to have a technical assistance center that did a lot of training around evidence-based practices, and having a support structure. If you have multiple sites you're working with, so if you're within a state and you want multiple hospitals, having training, having consultants who can go visit the places, see what's happening, give feedback, really is a very helpful thing. And a lot of the sharing among sites, so having like monthly calls or setting up peer-to-peer consultations where people can talk to each other about what they're doing, like learning communities, is really helpful in that implementation structure. Yeah, good question.
Thanks so much, Michelle, and thanks, Emily, for answering some of the other questions in the Q&A feature. We have another from Melanie Smith saying, I work on an inpatient unit with kids, so I know this was about veterans, but what were the e-health things you used with the patients that maybe I can have some ideas?
Yes. Oh,
go ahead.
Oh, yeah, so we used, we weren't necessarily implementing eHealth, but with some of the things that we observed were like using tablets for video chat with various providers off the unit. Also with access, they could use the tablets to access different mental health apps. They created, some of them had built-in computers like in the walls so that it was safe for the veterans to use. Some of them just had regular computers with nurses who were able to sit with the veterans while talking with providers off the unit or with family members, things like that. Michelle, am I missing anything?
Those were the main things. There was one site, so this all kind of came around because we were doing another study on what happened during COVID for inpatient care. And one of the sites there gave people tablets so that they could watch Netflix or things like that. So you would have kind of your normal access of video entertainment. And that was probably the more extreme or more liberal use of technology that we saw. Being able to access things like for kids, maybe being able to access their school hub or things like that. For adults, could they be able to access paying their bills or kind of other activities that you would normally do outside of the hospital?
Awesome. Thank you so much, both of you. We are almost at time, and I did want to let everyone know that I have put the link to our SAMHSA required survey in the chat so that you can access that and fill that out. And then if you need it, download a certificate of attendance for your records. We did have several folks in the chat ask for a copy of the paper, Michelle. So what is the best way for them to get a copy?
Oh, you can email me. I always do this thing in chat. If you want to share in chat something you're taking home from today or that you learned, I always love to see that. But just email me and I will send you copies of any of the articles that we talked about today. Or if you have other questions about recovery-oriented care, I'm always happy to answer those questions. So, yeah.
All right. Thank you so much, Michelle. Thank you so much, Emily. That is going to conclude our webinar for today. Please email Michelle and Emily if you'd like a copy of the paper, and please remember to click on the SAMHSA required link in the chat to fill out the survey and get your certificate of attendance. Thank you so much, everyone. That will be it for today. Have a wonderful rest of your Wednesday.